Welcome to the deep dive. Today, we are taking a single deep cut into the heart of emergency medicine judgment, specifically tailored for those of you navigating NHS specialty training. Royal College of Emergency Medicine Specialty Learning Outcome 2, or SLO 2.
This really is the skill, isn't it? SLO2 is titled, Support the ED Team by Answering Clinical Questions and Making Safe Decisions.
Which sounds simple enough.
It sounds simple, but we're talking about mastering clinical judgment in a setting where, the information is incomplete, the pace is just frenetic, and the acuity is constantly shifting.
Right.
So achieving this isn't just about passing your ARCP, it's about becoming a genuinely safe and independent emergency physician.
Our mission today, then, is to give you a roadmap. We're going to review the formal requirements, what RCEM actually expects at core, intermediate, and higher specialty training levels.
And then crucially, we'll spend most of our time diving into the practical, tactical strategies and the cognitive aids you can use immediately to mitigate diagnostic error.
And that mitigation seems to be the central pillar of mastering SLO2.
It has to be. The emergency department is often described as, well, almost a perfect storm for diagnostic error. You're managing complexity, constant interruptions, systemic fatigue, and your own intrinsic cognitive weaknesses.
So you need systems.
Exactly. You need systems internal and external to protect your judgment.
Okay, let's unpack this. Let's start by establishing the goalposts.
Okay.
What does the RCEM curriculum actually demand from you to tick this specific box?
Well, to progress, you have to demonstrate competency using a whole variety of evidence. This means you need a learning plan to gather feedback through things like a case-based discussion or a CBD.
Which shows your clinical reasoning.
Precisely. And then there's the mini-CX, which is about your consultation skills, and the multi-source feedback, the MSF, which covers professionalism and how you interact with the team.
So it's not just documenting the outcome of a decision, it's showing the process of how you got there.
Exactly. And the expectations, they increase substantially as you advance up that training ladder. For core trainees, that's level 2B, you're not expected to be entrusted to answer every clinical question on your own yet.
Okay.
Your main focus is showing you have sound underpinnings for your decision-making. So demonstrating an explicit understanding of diagnostic methodology, cognitive bias, and, when to use decision rules and guidelines. You're basically mastering the recipe.
But then by the time you reach intermediate training, level 3, that shift is pretty significant.
Oh, it's huge. By the end of intermediate training, so when you're starting HST at ST4, you must be able to practice without direct supervision in this activity.
Wow.
Yeah, your faculty entrustment statement has to attest that you're ready to support the ED team, relying only on a consultant by phone for maybe the really complex cases. You become the primary decision maker for the department's flow.
And then the pinnacle, the end of HST, level 4. That requires a truly advanced synthesis of these skills.
Level 4, it requires a profound understanding of diagnostic reasoning.
Okay.
And the ability to apply it effectively in that chaotic EM setting, and, crucially, the skill to communicate these principles to others.
So teaching and mentoring trainees below you.
Exactly. Markers of excellence include a readiness to adapt and develop these skills across different contexts.
That phrase, profound understanding, it implies that knowing what to do isn't enough. You have to know how your own brain can work against you.
Yes.
Which raises an important point. If level 4 requires this mastery, we first have to confront the cognitive threats inside our own heads.
That's the vital step.
Yeah.
If we look at decision science in medicine, we rely on what's called the dual process theory. It's this fundamental split between System 1 and System 2 thinking.
And System 1 is pretty much where we live in the ED.
It is. System 1 is fast, it's intuitive, it relies on immediate pattern recognition and heuristics. It's what allows an experienced consultant to just glance at a patient walking in and immediately generate 2 or 3 viable differentials.
Right, that gut feeling.
It's the gut feeling. It gives us speed, which is essential for resuscitation and rapid triage, but it is highly susceptible to the cognitive shortcuts that lead to error.
And then there's System 2, the deliberate thought.
System 2 is the opposite. It's slow, analytical, and requires significant, effortful concentration. We use S2 to check S1, or to review information that doesn't quite fit, or to work through a truly undifferentiated, complex case.
But the ED environment is constantly trying to sabotage System 2.
Completely. The noise, the interruptions, the lack of sleep, it's all eroding the resources you need for that kind of deep thinking.
This is where it gets really interesting. The specific cognitive biases that just thrive when System 1 runs unchecked in a busy department.
We see them every single shift. For example, anchoring, premature closure, and diagnostic momentum often go hand in hand.
So you fixate on the initial idea.
You fixate, and it's often reinforced by a subtle triage cue. You see a patient's been put in the minors area, and you subconsciously just lower your index of suspicion. You stick with a simple diagnosis even when later facts contradict it.
We also see availability bias all the time. If you just missed a subarachnoid hemorrhage or you had a really complex PE case yesterday.
You're naturally more likely to overestimate the probability of that condition in your next patient with a headache or shortness of breath. It's just human nature.
And we can't forget the interplay of emotion, effective error.
While we all aim to be objective, exhaustion, or your personal rapport with a patient, or even dislike, it can subconsciously influence your disposition. You might over-investigate a case because you're anxious, or just as dangerously, prematurely discharge a difficult patient.
So managing this emotional terrain is part of the professional development for SLO too.
A huge part.
Given that fatigue is an inescapable systemic reality in our work, how do we operationalize a personal cognitive timeout?
You have to first recognize the physiological threats. The mnemonic HLOT, hungry, angry, late, tired. It isn't just acute suggestion, it's a self-check mechanism. It's a trigger that forces metacognition. It encourages you to step back and recognize that if you're deeply fatigued or emotionally dysregulated, your risk of cutting corners and relying on faulty System 1 thinking just skyrockets. You have to consciously stop and shift gears.
It sounds great in theory, but when you're mid-recess or running 5 sets of jobs, stopping to outing requires, well, a lot of internal discipline.
It does.
So if metacognition is thinking about how we think, what structured tools can we practically use to force System 2 thinking when the pressure is highest?
The foundational strategies are mandatory. You have to routinely consider alternatives. You have to deliberately fight premature closure, and you must always attempt to disconfirm the diagnosis.
Ask yourself what doesn't fit.
Exactly. What piece of information in this patient's presentation absolutely does not fit my current working diagnosis? That's the question.
Let's use an example of a structured approach, something like the SPO-TDX method, which is designed to make that initial broad list of differentials more manageable.
Yes. It's a great tool. Let's take the classic case. An 85-year-old female presents with acute shortness of breath and mild chest discomfort. You'll see this case 10 times a week. The SPO-TDX process is a deliberate filter.
Okay, so we start with S for serious. What requires immediate intervention? What could kill her now? Myocardial infarction, pulmonary embolism, aortic dissection. We have to exclude those first.
Right. Next is P for probable. What are the common things that fit her age and history? Probably a COPD exacerbation, maybe heart failure, pneumonia.
Then comes O for outliers, Heather. This is the crucial moment where you integrate specific facts that might not quite fit the probable bucket.
This is the key step. Let's say she has a clear chest, low oxygen sats, and a history of recent long-haul travel. Suddenly, the outlier category, PE, starts moving way up the list because it fits the objective facts better than the COPD or pneumonia diagnosis.
And finally, T for timeout. This is the explicit check.
This is where you run the HALT assessment. You check for diagnostic momentum. Did the triage nurse write viral cough?
Yeah.
And now you're stuck on it. And you assess if the patient is stable enough to allow for deliberate investigation.
The beauty of something like SPO-TDX is that it refines the differential to a high-risk suspicion. It guides you to immediate testing, like a D-dimer or a CTPA, even if the initial presentation was a bit vague.
And it forces you to document why you ruled serious diagnoses in or out, which is precisely what demonstrating SLO2 mastery requires.
We touched on reasoning earlier. Most of our training relies on hypothetico-deductive reasoning. You start with a hypothesis and then you test it. But how do we engage that alternate, slower System 2 process of inductive reasoning?
Inductive reasoning is it's fact-driven and pathophysiology grounded. You build a hypothesis from the observations rather than testing a pre-existing pattern.
Give me an example.
Okay, think about sepsis. You don't just see a patient who looks septic. That's S1 pattern recognition. Inductive reasoning means you look at the labs. Lactate of 4, pH 7.28, base excess 88, CRP 250, a neutrophil predominance. You build the diagnosis of septic shock from that accumulation of biochemical and physiological facts.
Which is much more reliable when you're facing an unusual presentation.
Hugely reliable, especially in compromised patients who just don't fit the textbook pattern.
Yeah.
That mechanistic thinking is essential for trainees, and it directly informs how we use our resources.
Right. So when ordering investigations, we have to operate on probabilistic thinking.
Absolutely. Diagnostic tests should revise probabilities, not confirm absolutes. This brings us back to the 2 to 10% rule for pretest probability, or PTP, for dangerous conditions.
Okay, break that down.
If your PTP is below 2%, say, for a PE, using a really stringent decision rule, the potential harms and costs of the investigation, radiation, contrast, reaction, incidental findings, they generally outweigh the benefit. You should probably consider no further testing.
And what about that critical gap, that 2 to 10% PTP?
That is the zone of clinical uncertainty. It's often called the plaintiff's gap in risk literature.
Right.
The diagnosis isn't common enough to mandate testing, but is not rare enough to ignore. And here, shared decision-making with the patient about risk tolerance becomes paramount.
So you have to articulate the risk versus benefit.
And collaborate on the plan. This is a critical marker of advanced decision-making, and it fulfills the safe decisions part of SLO2.
Okay, moving on from these internal safeguards, let's talk about the external tools we can use to offload that cognitive burden and create systemic safety.
Since the ED is such a high cognitive load environment, we have to intentionally use external aids, our external brain, to free up mental energy for critical thinking. This is why we use cognitive aids, taking lessons directly from places like aviation.
Right, the classic B-299 crash story from the 1930s. The aircraft was just too complex for a single pilot to manage takeoff without a checklist.
Exactly the same principle. Checklists and crisis manuals reduce cognitive load and prevent errors of omission, especially during high-stakes resuscitations. But the design is key. A good cognitive aid has to be minimalist.
What do you mean?
It needs short, concise sentences, maybe 7 to 10 steps max, and only the essential information. If it's too verbose or complicated, it just becomes part of the cognitive burden, and it defeats the purpose.
And what about documentation? Everyone sees it as an administrative burden, but it's actually a really potent forced mechanism for System 2 thinking.
It's a cognitive safeguard. Documentation is non-negotiable for risk management and communication. We should prioritize real-time documentation straight after seeing the patient to capture observations while they're fresh.
And for SLO2, there's a specific type of documentation we need to focus on.
Yes, rationale documentation. Explicitly state the reasons for not pursuing a certain diagnostic pathway or why a decision rule was not applied. This demonstrates to a reviewer and forces you to confirm for yourself that you actively considered the dangerous differentials.
In terms of managing flow and capacity, which directly affects our ability to think clearly, what are the most actionable strategies?
The main strategy is to combat the urge to multitask. See patients sequentially. Try to adopt a one-patient-at-a-time mindset to minimize task switching. But the most powerful System 2 technique you can use early on is planning for negatives.
Explain that concept.
Planning for negatives means that right at the outset of care, you plan the next steps for when your tests come back negative. So, for example, if you send a CT for suspected appendicitis, you decide before the result comes in. If the CT is negative, what happens next?
Will they go home, get an ultrasound, be observed?
Precisely. By pre-deciding these actions, you offload the System 2 cognitive demand from the moment the result drops. You're not left panicking or closing the case prematurely.
And when we formulate that final disposition and the safety net, mnemonics can provide that final structural check.
Yes, they're great for making sure nothing is missed. For plan formulation, using a structured mnemonic ensures completeness and safety. DDIVITS is a pretty comprehensive one.
Okay, run us through it.
It stands for drugs, diet, activity, vitals, investigations, interventions, disposition, organized follow-up, medications, explanation advice, and safety considerations.
That's a lot.
It is, but imagine discharging that 85-year-old female after ruling out the serious stuff. You use DDIVITS to check. Her new medications are compatible. Her vitals were checked one last time. She understands her safety netting advice, and crucially, that the plan for GP follow-up is organized. It ensures nothing slips through the net.
Finally, let's address feedback loops. These are so critical for long-term judgment calibration.
In emergency medicine, we often learn from our mistakes, but our successes are often just protected by luck. It's called the feedback sanction. You can't learn if you never know about your errors of judgment in routine cases.
So you have to seek it out.
To truly master SLO2, you have to actively follow up on routine patients, not just the adverse events, to calibrate your judgment about what normal care actually looks like.
That brings us full circle, doesn't it? Achieving this specialty learning outcome requires developing these robust internal systems, like metacognition and structured reasoning alongside external systems, like cognitive aids and deliberate documentation.
The trajectory of an expert EM professional is really defined by their capacity to be deliberate about their thinking and to actively assess and regulate their own cognition. Mastery is the profound understanding that you are your own weakest link, and you have to build professional systems to protect yourself and your patients.
We have to recognize our own limitations. The emotional and cognitive demands of EM constantly challenge us, causing what's called the vigilance pendulum to swing.
That pendulum swings between hypervigilance and overtesting right after a bad miss, and then on the other side, complacency after many negative shifts. Experience helps dampen that swing over a career, but controlling it consciously is the definition of advanced judgment.
So, here is a provocative thought for you to carry into your next shift as you work toward achieving SLO2. We know the pendulum swings. What specific documented process will you use this week to consciously reduce the magnitude of that swing and calibrate your judgment in that middle ground of normal practice? Will you use decision journaling after every discharge, or maybe commit to reviewing the outcome of 3 specific patients you discharged 4 to 6 weeks ago just to assess the accuracy of your original prognosis? That deliberate long-term follow-up, that is the ongoing work of the expert physician.